So good morning. I'll just go over some required CME slides. So I have a grant. Your slides, please. Yeah. Yep. There you go. This is how you get the credit. So today we will talk about the anti-amyloid treatment in detail, as well as I'll go over our objective. We'll review the lecanemab and donanemab. They're two drugs that are approved by FDA, the mechanism of action and its effect size. We'll choose, I'll also talk about how to choose the appropriate patient for these treatment, as it's only selective for certain patients. We'll talk about Johns Hopkins experience or Johns Hopkins program, and identify some ethical issues and importance of disclosure at the end. So as we know, that accumulation of amyloid beta plaques is a defining pathophysiological process in Alzheimer's disease. There are two drugs that were approved, lecanemab and donanemab, which reduces amyloid beta as evidenced in clinical trial. So lecanemab was approved after Clarity AD, a phase 3 trial was approved. 1,795 patients. They were randomized into MCI. They were all MCI. Dementia with amyloid positive, randomized 1-on-1, placebo, and treatment arm. They were given bi-weekly infusions, and the primary endpoint was from change from baseline in 18 months in CDR sum of boxes. The key secondary endpoints were change in amyloid, clearance of amyloid, and then change in ADAS-Cog, which is a cognitive score, ADCOMS, as well as ADCS, MCI-ADL, which is the activities of daily living score, which is a functional score. So we'll quickly look at the this scan. This on the left side you'll see this placebo, and then the right side the lecanemab arm, and you can see after treatment, in 18 months, these beautiful, colorful pictures of the amyloid that has been cleared after 18 months by lecanemab. And here, this is a view of that after 18 months. You can see the blue line, the green line is the clearance of amyloid, and these patients at baseline had 75.5 centiloids of amyloid. After that, it is reduced. You can see this blue. This is a placebo, and then the reduction of amyloid after 18 months. Here you'll see a little bit of lag in in CDR sum of boxes. You'll see again the green line, which is again the lecanemab, and black is the placebo. You'll see patients, both group tend to decline. However, the decline is slower in lecanemab arm compared to this placebo. In about 6 months, you'll see the separation here, and then 18 months, you can see it. So what does it mean? Both are slow. So what does it mean? There's about 27% slowing in the lecanemab arm in decline compared to the placebo. So it's a modest improvement. Now there was a little bit more, slightly more improvement in activities of functional MCI-ADL, which is the activities of daily living. In 18 months, you'll notice that there is 37% reduction in decline in the lecanemab arm here. So now talk about quickly mechanism of the trailblazer, which is the Kisunla, the second drug. It was done also in 1,736 patients. Patients with mild cognitive impairment, same amyloid positive. There were the difference here is there were two primary analysis population based on the low tau as well as the combined tau. So when it was initially, this drug required, when the trials were done, tau PET scan in addition to the amyloid PET scan. Now, tau PET scan is not available in the market or is covered by CMS. Therefore, when it was approved, it was just dropped and said that patient just need amyloid scan. You'll notice this is 2/3 of the patient, about 68% population had low to medium tau, and about 31% had combined tau. Again, they were randomized. Combined means including low, medium, as well as the high tau. They included as combined. Yeah. So these patients were randomized. The infusions here is every 4 weeks compared to the every 2 weeks in the lecanemab arm. So now I have mentioned here dosage because I'll talk about the modifying dosing at the end. Kisunla was given, the patients were given 700 milligram IV every 4 weeks for the first 3 doses, followed by 1400 milligram afterwards. Now in lecanemab, the difference is that lecanemab is weight based. It's 10 milligram per kilogram. However, this is fixed dosing, 700 and move to 1400 afterwards. So the primary endpoint was IDRIS. This is a score which is a cognitive and functional score combination. So change from baseline in IDRIS. Key endpoint was CDR sum of boxes. Here it's not the primary endpoint, it's the secondary endpoint, including the clearance of amyloid and the same ADAS-Cog, ADCOMS, and ADCS, MCI, ADLs these are all cognitive and functional scores for the secondary endpoints. You'll see here, now, there are 2 graphs, one on the left side and on the other, on the right side here, this is a low, medium tau, and the right side is the combined tau. So you'll notice that patients who have low, medium tau, they both separate, they both have a reduction and decline. However, those who have low, medium tau, they tend to do slightly better. Like there was 35% slowing by donanemab at 76 weeks compared to 22% right here. 35% versus 22%. Now, there is a sub-study that was not published initially by donanemab, and I have to mention here that it's still an issue because they had only done the low, medium tau and the combined tau, but there is a population called only high tau. That group of patient, it's still about 1/4 or 30% of those patients are in general population. And this drug actually does very poorly with that group of patients. And with not able to do the tau PET scan, it's still a treatment challenge. So as you can see, low, medium tau did 35%, combined tau 22%, and high tau was even worse. So quickly jump on the ARIA. My agenda is full. So ARIA, as you can see, these are ARIA-E and ARIA-H on the right side. You can see this is severe ARIA-E because ARIA is based on the size. It's more than 10 centimeters, severe ARIA-E. And these are microhemorrhage, which you can count, ARIA-H. So what is the pathophysiology of ARIA? ARIA is caused by loss of vascular integrity and impaired clearance. Now, that leads to immune response. This basically the blood vessels of the brain, they tend to bleed. Patients who are receiving the anti-amyloid treatment, it breaks the blood-brain barrier. I'll show you a picture, next slide. And in order to understand this, we have to understand the process of how it works. You can see here, I don't know if you can see the colorful, this perivascular space is pretty clear in this normal, neuron. And in the Alzheimer's brain, this perivascular space is pretty jammed here, right? You can see this. And when you give this anti-amyloid treatment, these anti-amyloid attacks on these antibodies attacks on these plaques. These are plaques. These are here plaques in Alzheimer's disease. They attack on these plaques, and then it also further breaks down the perivascular space. You can see this breakdown of this blood-brain barrier, causing them to have leak. So there are 2 types of ARIA, ARIA-E and ARIA-H. E is edema. About 12% patients in lecanemab group and 23% patients in donanemab group had ARIA-E. ARIA-H was more, in 17% in lecanemab, 31% in donanemab. So you can see here that donanemab patients have more side effects of ARIA in both E and H. So the symptoms of ARIA, generally these are all the symptoms, headache, confusion, but the most common symptom is headache, confusion. These are the most common symptoms, headache, confusion. Rarely though, some patients who have experienced like severe ARIA, you may notice seizures and status epilepticus. Severe ARIA, especially ARIA-E, can cause, this edema in the area that can, is a focus of seizures. And then status epilepticus, only 2% of the ARIA types will be severe. Classification, we don't need to memorize. We'll quickly skip through it, but it's based on the size. And in ARIA-H, we counted the number of microhemorrhage. The more the number of microhemorrhage, the more severe the ARIA. Now, this is a patient with MCI with severe ARIA-E during lecanemab treatment. In A, B, you see the baseline MRI shows a mild degree of white matter hyperintensity. This is figure A, mild degree of white matter hyperintensity. You can see this on the periventricular area. And then 8 weeks later, this patient had a headache and confusion. MRI shows multifocal flare hyperintensities. You can see this. This is severe parenchymal edema, and in D image as well, you can see this both. This is severe after the ARIA treatment. This is not a Hopkins patient. Just this is again ARIA-E, baseline MRI. Now ARIA-E's can first happen. They can get better. After that, they can also recur after a certain time. A and B, you'll see this white matter hyperintensity, baseline MRI. And C and D, you'll see after 11 months into the lecanemab treatment, right here, these ARIAs, C and D. And 2 months later, after the resumption of treatment, patient actually redeveloped these ARIAs again in the occipital lobe. So what do we do with these ARIAs? We monitor them. And there are extensive, MRIs protocol, especially we are a little bit conservative. We wanted to rule out the later stage, ARIA. Therefore, we have added this 24th week, after 24 months. Generally, FDA has only approved 5, 7, and 14, but there are rarely, patients who will have ARIA later on during the treatment. So 24 weeks. In lecanemab and in donanemab directly attacks on the plaque. Therefore, the ARIA usually happens very early in the treatment compared to the lecanemab, which basically breakdowns on the protofibrils. So 2, 3, 4 for Kisunla or donanemab, 2, 3, 4, 7, and 12. So there are more MRIs scheduled for the Kisunla or donanemab group. There are some MRI exclusions, and I have to say this is extremely important to have a clear MRI. The more clear the patient's MRI is, the better it is, and it will avoid side effects. So anyone who has more than 4 microhemorrhage, this we should not give infusion. It's going to increase the chances of ARIA-H drastically. A single microhemorrhage, area of superficial sidrosis. That's why pre-infusion MRI with the 3 Tesla machine is extremely important. Anyone who has more than 2 lacunar infarcts or Fasiga score above 3 and has, they are excluded. Patients who have ApoE44 homozygous, we do not give infusion. FDA has not, advised such, but CAA, cerebral amyloid angiopathy, and patients who are on anticoagulants. And the reason we have not chosen ApoE44 because the risk of ARIA increases significantly. Moreover, we know that patients who have ApoE4 leads to more deposition of, more breakage of the blood-brain barrier, and it's actually ApoE44 homozygous patients are more prone to have their brain imaging is similar to those as of cerebral amyloid angiopathy patients, CAA patients, and it increases the risk of brain bleed. So anticoagulants other than aspirin and Plavix increases the risk of bleed in lecanemab group. We have advised that patients who are on anticoagulants will be excluded from the treatment with lecanemab. Now this is by genotype. As you can see, patients who have ApoE44 homozygous, the risk of bleed is 42%. That is what I was saying earlier. And those who have carriers, 23, and non-carriers, 13. This is now, as stated earlier, the number of microhemorrhage, as it grows up, the number of ARIAs goes up. You can see patients with 1 microhemorrhage, no microhemorrhage, you can see this 38%, 1 microhemorrhage 47. Those who have 2 to 4, 82%. That's significantly higher. So the more clear our patient's MRI will be, it's better for the prognosis. So this is what I was talking about, Trailblazer, which is all-6, which is the new modified titration dosing of Kisunla, which is the donanemab. So they came up with this idea. It's not yet FDA approved, but it would likely it's presented that modified titration is that, you know, they give infusion number 1 will be at 350 milligram, 350 mg, and then increase to 700, and then 1050. So the first 3 doses, it will gradually go up, 350, 700, 1050, and then 1400. And you can, it reduces the rate of ARIA. I'll show you in the next slide. Here it is. This is, the blue is the standard arm, and the red one you can see the modified dosing. 57% compared to 19%. Likewise here in the homozygote. 5% and no, this is symptomatic ARIA, this is non-symptomatic. So you can see in both the patients who are with modified dosing did far better than those with the standard dosing. Now, the question is it still efficacious? So they did check the amyloid clearance, and the amyloid clearance was equal in both standard dosing as well as modified dosing. But because the most risk of ARIA is in the initial stages, on the first few bleeds, it reduces the number of ARIAs. So, as you may have noticed, our patient is wearing this bracelet, TPA. So, any patient on lecanemab cannot have TPA. Any patient on lecanemab may not get TPA. And the question is why, right? TPA, this lecanemab or any anti-amyloid treatment, it stimulates the microglial activation, which attack the blood vessels, causing necrotizing vasculitis. And this drug, monoclonal antibodies, they form fibrin around this. Fibrin is the target of TPA. The fibrin attacks as the target of TPA, resulting in massive bleed. And here is the picture. This is not a Hopkins patient. This is just a, presentation. You can see multiple, multifocal bleed. So who's the appropriate lecanemab patient? Anyone who has MCI. Age 50 to 85 is generally they were represented, they mentioned, but it's broadened. Our goal is to make sure that the patients are in the mild stage, MCI stage or mild dementia. Therefore, we initiated this CDR, instead of CDR sum of boxes, we came up with this score, QDRS, which is a quick dementia rating scale. Score of 2 to 11 is normal. We want to take the more mild the patient is, the better it is. 2 to 8 is what we consider for the program. And then anyone who has a TIA within last 12 months, we recommend not to get the treatment. And anyone on anticoagulants, we recommend, that will be excluded. ApoE4 for homozygous is excluded. In general, anyone, severe depression, anxiety, or psychosis. Now here's the immunological condition. There are many patients who will present with RA, Crohn's disease, ulcerative colitis. We usually recommend patients who have or any other anti-amyloid treatment not to get lecanemab or donanemab because they compete. The two mAbs compete because they also work through the immune system. When the immune system is suppressed by other mAbs for Crohn's disease, this drug is not going to work. So for the Kisunla or donanemab, the only difference is, first, as I mentioned, we only do the amyloid PET scan. We don't do the tau. And patients with anticoagulants may receive this, drug because it does not affect, patients on anticoagulants. The only caveat here, as I mentioned, we don't have a tau scan. Therefore, those patients who have high tau, we are not able to, those patients will not benefit. We just have to disclose them. So this Johns Hopkins lecanemab program, we set up the infrastructure, and initially this drug was approved in, it's quite labor intensive, and multiple systems is involved, including the neuroradiology, memory clinic, infusion center, and we initiated the leadership meetings. This drug was approved by P&T committee. We developed the patient education, and then after that, the provider education as well, education of the nursing infusion staff, because this is all new. This was, and then this patient, anyone who has ARIA, usually go to the ER, and the first thing that the ER physician does is a CT scan or CAT scan. This drug, these ARIAs are not seen by CAT scan, therefore we have to educate the staff, ER physicians, to do the MRIs. MRI protocol was set up, and thanks to our radiology team, neuroradiology team, so then we developed a pre-infusion checklist that an additional visit at the memory clinic or wherever the patients are, the neurology clinic. So our program includes patients from neurology, patients from the early onset dementia clinic, and the memory clinic. And there are several satellite sites of neurology. Those all patients are referred through the Johns Hopkins. Each patient is registered through Johns Hopkins, precision medicine registry, and we do verify the APOE status, QDRS, making sure that we have the updated one, consent. Each patient is also registered with Medicare. Medicare has a registry for this, and they want us to update the registry every 6 months to make sure that there is any updates regarding ARIA or anything else that's going on with the patient. And we have a special protocol of our MRI, ARIA protocol. Then we provide extensive education to the patients, family members, as well as the patient, but all staff and family members are alerted. We have a 2 or 3 tier, we can say check line to make sure that the patients who are receiving the drug, if they have an ARIA, it's reported to the doctors. Doctors then report to the infusion center. So it's all making sure that it's all done. And each patient receiving lecanemab or donanemab will have a medical bracelet that will say that patient on lecanemab cannot have TPA. And these patients are followed every 3 months at the memory clinic by our nurse practitioner for outcomes visit. So this is the demographics of our lecanemab patients. We have 44 patients active, 4 pending, 44 lecanemab patients at the moment. As you can see, the average age is 71, and we have 90% white, about like 6% black, African American, and majority of our patients are college graduate. And then generally, 64% patients have E3, E4 heterozygous, genetic structure. Initially, the issue was that this drug was only approved, PET scan was not approved, but the drug was approved. So all these patients had to get the CSF testing. So 50% of our patients have the CSF testing done, 50% of the patients have the PET scan. Comorbidities, 56% patients have hypertension in our cohort, diabetes about 16%, and likewise chronic kidney disease. Now this is interesting. CKD patients have 25% patients have CKD. We have ARIA rates at Hopkins program is quite significantly lower compared to, I'm not privy to, or I shouldn't say I'm not allowed to speak the name of the other academic centers, but I can only tell that the rate of ARIA is about like 22% in one, and then 28%. I've talked to 2 huge academic centers, and our rate of ARIA-E is 6%, and ARIA-H is 11%. So there's a difference, and we have, we know that patients who have these ARIAs, we have moderate ARIA-E. All those ARIAs are asymptomatic, and majority of these patients have E3, E4, heterozygous. Some of them have, like mild ARIA-H with the E2, E3. And the only thing that we've noticed that, patients who have pre-existing microhemorrhage, 1 or 2, they are more prone to having ARIA. So 44 lecanemab patients. Then we have donanemab patients that are waiting to get infusion. We have 10 donanemab patients in addition to 44 that are going to get infusion. So this is a little skewed, 80% male. Generally, we have more female in our program, 20%. And again, college, same, 80%. Majority of them have college education. And E4 heterozygous is 90%. And here, PET scan 70%, and 30% has CSF testing done. So our program, is expanding. We are expansion, and we have a research assistant, anti-amyloid director, and other providers. We do a weekly meeting of those difficult cases, and neuroradiologist and infusion center. We have a monthly meeting on that. And we choose the appropriate patient, make sure that appropriate patients are entered into the program, verify the patients are scheduled for MRI. So, Nadia is a wonderful research assistant. She helps with all those. And I'll just do, so expansion-wise, we are doubling the infusion chairs at Johns Hopkins Howard Community Site starting February, but it might delay a little bit. Currently, we are at 80% capacity. We are using 4 infusion centers and 6, MRI sites for the Johns Hopkins, all in the Johns Hopkins network. And the MRIs, we're still able to do it. One thing additional that we will be able to hopefully do in the next few months will be the patients who are on pacemaker. Usually it's harder to get patients who are on pacemaker on scheduled MRI. That will be done as well. So what's in the horizon? Subcutaneous Leqembi is a maintenance is in the horizon, and once monthly maintenance for lecanemab is on the horizon. However, we just learned this morning, basically I looked at the FDA approval that it was approved yesterday, once monthly lecanemab IV infusion after 18 months of lecanemab is approved by FDA yesterday. We just got to know today. So now the last topic, ethical issues. So especially disclosures and ethical issues are extremely important in this program. Advanced care planning for non-emergency conditions such as new onset atrial fibrillation, which may require patients to be on blood thinners or in anticoagulants. As we know that patients who are on lecanemab program, they may have an increased risk of brain bleed or ARIA-E if they are on anticoagulants. So we have to disclose that as well. 10 to 12% Medicare beneficiaries with a diagnosis of atrial fibrillation and need for anticoagulant for stroke prophylaxis. So, and then we'll have to also, there's another issue here, is consider the 3 common acute conditions in patients who are receiving lecanemab, MI, if they happen to have an MI, coincidental MI, or ischemic stroke or pulmonary embolism. Thrombolytics are critical in those events, but what do we do in case, as we know that these patients, when they start the treatment, usually the half-life of this drug is about like 45 to 60 days. Usually the clearance half-life, 15 days is the half-life, but generally 15 to 20 days, but clearance half-life is longer, so they still may bleed. So this is really something that we have to discuss with the patient as well. So really, is the glass 3/4 empty or 1/4 full? This is the question I have. With all of this, 18 months of treatment, as I said, that there's a modest benefit of this drug. As you can see, delays cognitive decline, reduced clinical decline by 27%. It does clear the amyloid, and it does it beautifully, right? We know that as I usually say, it cleans the amyloid as if the vacuum cleaner would suck the dust. ADAS-Cog slowed by 26%, ADCOMS 24%, and all those 37% in delayed, like functional decline. So what it does, in general, 27% decline means, slowing in decline means that in 18 months, it reduces decline by 5.5 months. So if you follow the course, now this is not in any publication, but this is our Jeff Cummings' words that, if you extrapolate these 18 months into the dementia course, which is 9 years or so, we can say that it delays decline by about, someone's going to the nursing home by 4 to 6 years, based on the reduction in the functional decline, which is 37%. So modest size, effect size, and then the rate of ARIAs. However, we know that the rate of symptomatic ARIA is significantly lower compared to the rate of ARIA, asymptomatic ARIA. So another issue is we don't know the long-term sequela of ARIAs still, because the drug is just in the market for the last few months, last few years. So having said this drug is for only a select group of patients who have clean MRI. It's not for everyone, but for those, it worked. It really worked. As we can see from our patients, they are very happy. And this is an FDA-approved treatment. We're providing it for the patient. Here I'll end. Thank you so much for being, for being with me and attending this grand round. Appreciate it. I'll be ready for the questions.
Thank you very much. I want you to come back to the mic because we're going to have questions for you. It's great. It's so interesting to see the real-life experience with this drug that many of us have thought about and heard about. Let me ask you this. If someone has mild cognitive impairment or early dementia and a clean MRI, do you recommend that they start this treatment? Or do you present it as here is something that could be done and talk about pros and cons?
I presented that these are the options, treatment option, and so generally also present the alternate option that there are only medications available, and then what's the prognosis of each and the risk and benefits and side effects, and we do the full disclosure, but we do present it as an option.
Okay, and what percentage of people have opted for it at this point?
Initially, there were only like about 30% who were opting for it. Now, I would say that about 60 to 70% patients are not only opting for it, they're especially coming to Hopkins Memory Clinic asking for it.
Okay, thanks. Interesting. Let me see if other folks have questions. Dr. Anyike. I'll just paraphrase the question for people who might be watching remotely. What's the long term? How does the long term look with regard to this treatment? Should it go on beyond the 18 months?
So there are two drugs. Both have different. There are two answers for this. For the lecanemab, as I mentioned, that this was approved for monthly maintenance dose. So for lecanemab, although the amyloid clearance is undetectable after 18 months, it's a monthly infusion. That's what they're proposing because, the rate of reaccumulation is about, every 3 years, it'll reaccumulate to about 30 centiloids. However, for donanemab patients, which is the second drug, after 12 months of treatment, you rescan the patient. If the amyloid is undetectable, you basically stop the infusion. And they haven't come up with this, but I think the plan would be if they start decompensating and they have 4 or 5 years, but at the moment, you stop the treatment. So one has exit strategy, the other drug does not have exit strategy.
That's helpful. Okay. Dr. Mali.
So it's a good question, excellent question. So I think we are also in the process of.
Yeah, maybe just paraphrase the question.
So the question Dr. Malik asked was that there are two questions. How do we measure tau since we do not have the tau PET scan available? And the first one he asked, how do we compare it to the acetylcholine or anticholine, cholinesterase inhibitor? So the answer to the tau question is that we do not have tau PET scan. However, there is a CSF tau MTBR 243 and p-tau 205 that is available, but it is not available. It's not available in the market yet. At the end of the year, we will be able to have these patients do, hopefully, the CSF testing to determine the tau level. For now, there is nothing available. We just disclose that patients are, and it's something that bothers me too, because about 30% of the patients have high tau, and the drug doesn't work for them. So this is one, and then the second question was, is it equal to the anticholinesterase? So these cholinesterase inhibitors, these work for about a year the most. About during the time that it works, actually they do almost equally good or slightly worse than the anti-amyloid treatment, but in the long term, they have shown the decline over the period of 18 months and beyond. I think the rate of disease, these are disease-modifying treatments, so they do a little bit better than that.
Thanks. Other folks? Dr. Rivkin.
It also depends on the stage of the ARIA.
So I'll just repeat, right? Do
Yes.
you abort the treatment if the ARIAs are positive over several images?
So you abort the treatment only if the ARIAs are severe or moderate symptomatic. So there is a protocol. I mean, it's how do we? So there are the two things that we have done. One is the stage of ARIA. The second thing is symptoms. Patients is asymptomatic, then only patients who have severe ARIA we stop the treatment. Otherwise, we can just do monthly MRI. And there's a whole ARIA protocol that was beyond the grand rounds that but yes, we have that we follow.
Thanks. Other folks? Dr. Margolis.
So the question was, does the outcome measures were taken into account for patients that the graph I showed, or they were excluded from the outcome? Our patients with ARIA were excluded from the outcomes. No, the outcome measures were inclusive of those patients who have ARIA, including those patients who have ARIA E and H, both.
Maybe I'll ask one more. Anyone else? Yeah, go ahead. So the questions, do these treatments affect tau levels?
So in the CSF, the lecanemab treatment shows that it reduces tau, but not significantly. It reduces tau. P-tau 181 is what they measured. And in the donanemab arm, we don't have any clear evidence that it reduces tau. So it's an anti-amyloid treatment. The downstream effect of tau is reduced because the amyloid, then we believe leads to tau. Because of that, some of the tau will be reduced, but it won't clear the tau, if that's what the question is.
Good question. Good question.
Very good question.
Yeah, well, thank you very much for a very, very interesting round.
Thank you.